Today, I am going to issue one of many public service announcements regarding care partners. Transplant care partners are the backbone of actual recovery, not just good intentions. They are the reason medications get taken on time, the reason infections are caught early, the reason a fragile graft survives nights, weekends, and holidays. They are unpaid case managers, night shift nurses, and safety officers for the people they love. And the current system treats that labor as if it costs nothing. Every transplant has two patients. One gets the organ, the other becomes the unpaid, unprotected worker who holds the entire system together and is treated as disposable for it. Transplant care partners are not a nice to have, they are the condition of access. No care partner, no listing. No caregiver, no transplant. No caregiver, no successful outcome for you to cite in a hearing or a press release. Care partners bleed out their savings, their sleep, their jobs, and their mental health to keep someone else's organ alive. Studies across solid organ transplants show that roughly 1 in 5 caregivers meet criteria for clinically significant depression at any given point, and around 1/3 will develop major depressive disorder or an anxiety disorder over time. Sleep research shows that most care partners report poor sleep quality, frequent night awakenings, and insomnia, symptoms that directly erode their own health and functioning. Hospitals and transplant programs know this. They require a reliable caregiver in order to even consider a patient for listing. That is not charity. That is mandated, unrecognized labor that props up a multi-billion-dollar transplant system while being valued in law at $0. And the people responsible for that system have names. Dr. John Maggie, president of the OPTN Board of Directors. Dr. Shelley Hall, vice president. Mr. William Bill Ryan, vice president for patient and donor affairs. Dr. Alan Reed, treasurer. Mr. Justin Wilkerson, secretary. Mr. Doug Fessler, executive director of the OPTN. Dr. Maureen McBride, Chief Executive Officer of UNOS, the contractor that operates the OPTN. Your signatures sit on policies that demand care partners for listening, discharge, and follow-up, while offering those same caregivers no pay, no leave, no mental health support, and no safety net when they break. The transplant system counts on their exhaustion and calls it family support. In Congress, health policy also has names. Senator Bill Cassidy and Senator Bernie Sanders, who lead the Senate Committee on Health, Education, Labor, and Pensions, oversee hearings that can open or close the door on caregiver protection. Representative Jason Smith and Representative Richard Neal, at the helm of the House Ways and Means Committees, write the tax and Medicare laws that decide whether transplant care partners are recognized workers or invisible ghosts. Representative Brent Guthrie and the members of the House of Energy and Commerce Subcommittee on Health supervise Health and Human Services, Medicare, and the very policies that make a reliable caregiver mandatory, but never measure caregiver injury, burnout, or financial collapse as a safety issue. Here is the reality your decisions create. A care partner who screens positive for depression, fights insomnia, and works a second unpaid night shift at home is the one catching medication errors, missed labs, and early signs of rejection before they become disasters. When that care partner crashes, panic attack, car accident from fatigue, heart event from chronic stress, there is no code called no replacement, no plan. The chart simply marks the patient is non inherent and the system simply moves on. National caregiver data consistently show high levels of psychological distress, with substantial proportions reporting anxiety, depression, and serious strain. Transplant caregivers carry that burden with the added pressure of knowing a missed dose can mean graft loss or death. If you require a transplant care partner, you own what happens to that care partner. That is not a slogan. That is a chain of responsibility. So this is the ask. State it as clearly as the consent forms your systems live on. To the OPTN board, UNOS leadership, acknowledge transplant care partners as the safety critical members of the care team. Build caregiver burden and mental health metrics into your quality framework and require programs to document how they will support, not just extract from, care partners. To Medicare and Health and Human Services, incorporate caregiver depression, burnout, and sleep related impairment into patient safety and quality indicators and pilot benefits that recognize the economic and health costs of this labor. To Senate Health, House Ways and Means and Energy and Commerce, stop treating care partners' labor as invisible in statute. Direct formal studies, hearings, and report language that name transplant care partners explicitly and lay the groundwork for leave, training, and protections tied to transplant episodes of care. We are not visitors. We are the care team. The data already show that depression, burnout, sleep loss among family caregivers are widespread and damaging. In transplantation, those harms are welded directly to graft survival and patient life. After the scar, we pay the price with our bodies, our jobs, our bank accounts, and our futures. You, named here, have the power and responsibility to stop pretending that price is zero.